Actually, it's really interesting because it was because of Yvonne. Years and years ago, in probably 1983 or 84, Yvonne and Catherine Jeter, Dr. Catherine Jeter, had these seminars, and Yvonne talked on pressure ulcers and Catherine Jeter talked on incontinence, and it was a 2-day seminar, and it was in Indianapolis, and I worked at a 500-bed long-term care facility in Fort Wayne, Indiana then for 25 years. And I saw this and I thought, that's really neat because I don't really know that much about pressure ulcers. So another nurse and I went to Indianapolis to this seminar, and Yvonne was doing it on her own by herself. And Dr. Catherine Jeter had some health issues in her family, so she wasn't able to go. So Yvonne did the pressure ulcers and she did the incontinence. And so it was really nice. I got Yvonne back before she even did the SAWC. And she's such a genuine, radiating person. And so I went back to the facility and looked at pressure ulcers really differently after having spent 2 days with Yvonne, and sort of understood how we need to really think about this and organize it and categorize it. And so in 1983, I started probably one of the very first wound teams in a long-term care facility in the United States. And this was back before computers, so that's really kind of hard to believe. But I had a spreadsheet, and so every week I would go around and look at all the pressure ulcers in the institution, and I'd put their name down and I'd put the location and the size, and every week when we would check it, it would be myself, the head nurse on the floor, even sometimes the aide, the dietitian sometimes would go with us, the director of nurses would go with us, and then we would consult with the medical director. So we actually kept track of every pressure ulcer that we had, and the location and the stage and the size. And on that spreadsheet, I would highlight it in one color when it was new. I would circle it in red when it got bigger, and then when it healed, I had another color. And then when they died, I had another color for that. And so as time went on, when they had the very first National Pressure Ulcer Advisory Panel meeting in Washington, D.C. in 1989, they were looking for how many pressure ulcers are there in the United States. And back then, we really weren't keeping records of how many they had. And they found out that I had 5.5 years worth of data on these pressure ulcers, and the only reason I had the data is because we're a county-owned facility, so we kind of have big rooms and old file cabinets, and so I just kept putting those papers in the file cabinet and never threw them away. So I was able to go back and look at data for 5.5 years worth before they even had the very first National Pressure Ulcer Advisory Panel. And truly, that's all because of Yvonne. I think the most significant change is several things. And you have to remember that I've really practiced back when we didn't wear gloves. I mean, that's really hard to believe. But I think in my institution, since 1976, actually, some of the biggest changes I've seen in wound care, and this sounds really old, but in our facility, in our 500-bed facility, we didn't have air conditioning. And so I had the statistics before air conditioning and the statistics after air conditioning. And what we found is a reduction in the incontinent-associated dermatitis and basically the candidiasis and things like that. But we didn't see a reduction as much as what I thought. So we're still trying to figure out what the humidity and what the climate, there's some other issue there besides temperature, because it did reduce the prevalence and incidence of that. Also, ulcers differently. Back in the olden days, it was something that nobody was taught and nobody knew what to do, and it was really just kind of old wives' tale things where you actually rolled them over, taped their buttocks to the bed rail, and put the heat lamps on it. And back then, every bed rail had old tape on it, and now we don't even really use bed rails. But I think the moist wound healing was very significant. The negative pressure is very significant. The new advanced wound dressings that we have. But I think more than that is when we get a pressure ulcer, we really look to see, why are they getting it? Is it because maybe they didn't get the care they needed? Or is it another issue? Is it because of nutrition? Is it because of age? Is it because of circulation? Is it because their blood sugar? Is it because maybe some of the medications that are on that reduce their ability to fight off this? So it's looked at totally different now. And also the litigation issues have started to come somewhat as a result of what they call the Purple Book, the prevention, the federal guidelines on pressure ulcer prevention that came out in, I think, '94. And the general feeling by the public that most pressure ulcers are avoidable. And so therefore, if you get a pressure ulcer, you did something wrong. But what we need to do, I think, as professionals, is to teach people that you can get a pressure ulcer because of bad care, but you can get a pressure ulcer for other things, not related to bad care at all. And if you look at some of the wonderful hospitals all over the United States that are really magnet hospitals, their pressure ulcer rate in their intensive care units is fairly high. And they're magnet hospitals. So it has to make you think that there's something else here besides poor care. And I think that's another issue that has really changed a lot, is that you look at why are they getting it and how can you help prevent it. Well, my expertise is in long-term care. And in our wound team, we really have everybody. And when we would make the rounds, again, as I said, we had the head nurse, we had the nurse's aide, we had sometimes a dietitian, the director of nursing, and we even had the pharmacist one time. Or not one time, but she came with us. And again, this was back in the olden days. And we had wards where we had 4 people in a room. And we noticed, it was in the summer too, and 2 people in that room had incontinence-associated dermatitis, but we didn't call it, we just called it diaper rash back then. And it didn't make any sense to me that there were 4 people in that room and 2 of them that they had incontinence-associated dermatitis. So I was saying, this doesn't make any sense, because all 4 people were basically on the same medication. They were basically 84 years old, and they could talk somewhat, but they needed fed and they needed turned, and they were incontinent of urine and feces, and they all had incontinent products on. So I said, I don't understand why these 2 have it and the other 2 don't. So we looked at the meds and they were all the same. And the pharmacist said, you know, I wonder if it has anything to do with the pH of their urine. So we got urinalysis on all 4. And the 2 that had the incontinence-associated dermatitis, their urine pH was 8.3 and 8.5. And the other 2 had a normal pH, which was more 6 or 7. And between 7 and 8 doesn't sound like much of a difference, but in urine and feces mixed together in an incontinent product in an older person with decreased skin tone, it really makes a difference. And so how do you lower the pH of the urine? You can increase their fluids. You can give them vitamin C. So those are two things that will help. And so what we learned is that when we have incontinence-associated dermatitis, we need to look at the urinalysis first and see what that is. And truly, if you just change the pH of the urine, the skin will heal up all by itself. But as you asked me, what new things have we seen? Another thing that we've seen is, back in the olden days, when you clean somebody up, all you really had was Vaseline. And in my institution in Indiana, it was a 500-bed long-term care facility. And what I noticed on Section 10, which all those people they couldn't really talk and they couldn't walk and they were all incontinent. And I kept noticing that on Wednesday, which was our pressure ulcer day, we never went to Section 10. And I thought, that doesn't make any sense, because these people are really more debilitated than some of the other people. So I just was saying, that why is this? And what I found out is that when the nurses' aides went around and checked the patients every 2 hours, and again, this was back before there were sinks in every room, and so they had to have these big tubs of water so that they could use them, and back when you used washcloths. So what I found out is that after they cleaned everybody up, they took the Vaseline and just slabbed it on them. And so it was early detection for me that the incontinent the incontinent creams and moisturizers and barriers made a huge difference in our first line defense. And as far as the disciplinary team, again, gee, I keep saying this, back in the olden days. Back in the olden days, in my 500-bed long-term care facility, we didn't have electric beds. It's not like you could push the button and the head would go up and the foot would gatch. So when you wanted to roll the head of the bed up, you had to put the crank in and crank it. And so when the head of the bed came up, the knee didn't gatch. And so we noticed that we were getting sort of a high rate of heel ulcers. And I think it was because when they raised the heel up, or raised the head up, more weight went on the heel. But in the hospital, they didn't have that problem because they had the electric beds. They'd push the thing, the head would go up, and the knee would gatch. So if the knee would gatch, it would take a lot of the weight off the heel. So we always made sure that when you raised the head of the bed, that you gatched the knee. So that was something that we had to teach them. But my point is that back in the olden days, when you raise the head of the bed up, there's no marking as to where's 30 degrees. And you want to roll somebody up not any higher than 30 degrees. So we had the maintenance people, every time we got a new pressure ulcer, we'd write the orders for the pressure ulcer, and then I'd write an order, mark the head of the bed at 30 degrees. So the maintenance guy would come up with his protractor, I think that's what they called it, and they'd roll it up, and then they would put a piece of tape, a red tape, on straight up and down when the head was 30 degrees, and then a piece of red tape on the frame of the bed, so that anybody would know where 30 degrees was. So at the end of so many years, we basically had every bed in the house marked. But here's the issue. The maintenance man then knew who all had pressure ulcers because he's the one who marked their beds. So when he was in there fixing the toilet or doing something else, he would remind them to do their 2-hour turning or to do position changes and things. Well, the nurses' aides did the turning, but he was aware of that and knew that they needed to move, and so he reminded the patient to move. And he would come and tell me different things about the patients that had pressure ulcers. I said, well, how'd you know they have a pressure ulcer? And he goes, well, you asked me to mark the bed. So it was really a wonderful interdisciplinary team. Well, it's changed. Again, early on, if you saw a new product, you just took it back and you used it. Now, it has to go through more of a formal entry kind of thing. And some institutions allow you to bring products back and try them, and that's not a problem. And some institutions, when you bring them back, they have to go through a committee before you can even use them. So the change has been, it's more difficult to get a new product in than it was years ago, but it's not that cumbersome. Well, that's a good question. Without naming names, I would say that the incontinent barrier films truly have made a huge difference. The switch from the actual washcloth that we know, the towel washcloth, switching from that to the commercialized cloths with the dimethicone and the incontinent barrier films already impregnated in it. That's made a big difference, I think. Just moisturizers for the elderly, for their arms and their legs to help prevent skin tears has made a big difference. And we have a population at the institution I work at now, which is in Tucson, Arizona. We have a lot of bariatric patients, which means they're 100 pounds or more overweight. We probably have 14 people over 300 pounds. And we have a 400, we have a 600, we have an 878-pound man. And what I've found in the bariatric population is, and especially in Arizona because it's dry in Arizona, but I think this is pretty normal for most bariatric patients. I would say to go, because there's so much to learn, from basics to really advanced. And it really is the best wound care conference in the world. And again, it goes back to Yvonne Fowler and Rob Kirshner, who then brought in the physician aspect of it, the Wound Healing Society, and there's something for everybody. And there's so much to say about the talking to your colleagues. And so a lot of times when you come back home, you've learned a lot in the conferences, but you've learned a lot just by talking to your colleagues about what they're doing and what's working for them.